we never really get compliments, and so I think the good way to judge how we're doing is the lack of complaints. There's been very few complaints about body MR in general. I just wanted to touch on just a few things. Protocol updates, I haven't really fiddled with protocol since 2015, so I'll probably be doing that. I have been doing that the last week or so, and hopefully I'll settle on that pretty shortly. I'd like to add a few things that we have not been doing in the past, and then we'll touch on just some recurrent issues. So I'm just going to get rid of the fibroid protocols for the female pelvis. I see this come up every once in a while. This is mostly tailored for IR practices that are going to embolize uterine fibroids, because fibroids will get blood flow from the ovarian arteries and the uterine arteries. And so when you run the dynamics in a coronal and a few other sequences in a coronal plane, it really helps to identify those arteries, and it helps them guide treatment, because they may need to block both arteries for them to successfully treat fibroids. So it's very kind of mundane, but I'm just going to go ahead and get rid of that. The traditional female pelvis with an contrast answers almost every question. There's been some questions about doing diffusion weighted imaging with the female pelvis. I'll touch on that in a second, and then I'm going to add a chest protocol. So there's been some, every month, about maybe every 2 or 3 months, there'll be a request to do like a mediastinal mass or something like that. And I'll hopefully send out this weekend or the weekend after that. So if you ever see an indication about endometrial cancer or cervical cancer, it probably needs to be scanned on the 3T. So I guess from an academic standpoint, there's an organization called FIGO, and they set out international standards for working at these malignancies. And they say that technically endometrial cancer is surgically staged. So you have endometrial cancer, you go and you get everything cut out, and then they see what your staging is. Cervical cancer should be clinically staged, so it's just what they can palpate, what they think of it, anything. But MRI shows such good detail of everything that we're actually pretty good at staging this better than clinical examination. So as this becomes more in vogue, I think you're going to see more and more of these. But most of the literature is based on 3T. So when you see an older Esprit 1.5T, it's really not the standard of care to diagnose these. So these are so rare, we don't get a whole lot of business from going on. But if you do see, again, endometrial cervical cancer, I would probably refer to CSWR, just let me know, and I'll coordinate with them. In general, I would favor adding, and that's, I guess, the only reason Fever is here, but they should probably add diffusion weighted imaging when they work these up, and I can work that out with them. But for the chest protocol, I'm going to send one of these out. Not a whole lot of places do these, but they can be fairly beneficial for mediastinal hilar masses in very specific situations. Same with pericardial masses, especially younger patients that have some random mass who thinks it's benign. They don't want another chest CT. We don't do cardiac or aortic MR very much, or at all. And chest wall masses, I would still just keep doing whatever MSK protocols we have now. Cardiac MR is a whole different beast. Cardiologists are really good about maximizing profits, and when they were losing money in other things, they started taking over cardiac MR. And this requires, a doctor really sitting at the scanner, you need nursing for administered meds. It's really complicated, so you really need a robust program. I don't think there are very many places in Denver to do it. I'm pretty sure National Jewish does it, I think the university does it well. I don't really know about anywhere else. And anytime you see one of these, I would always just run it by one of us. Every once in a while I'll see one pop up after Lutheran, and say, where did this come from? This doesn't make any sense. So please don't hesitate to let us know if you see these or get an order for this. Some recurrent issues. So the one thing, the Siemens scanners will sometimes, same with G, will auto-generate things. So if you do like a Dixon in and out, it'll auto-generate a water only, and it'll auto-generate a fat only. And you don't need to send over some of those. Like you don't need to send over the fat only and the water only. Sometimes when you do the Vibes, which is really also a Dixon, it'll also send over the non-fat SAS, which I think is really the fat only. And the this happens quite a bit. What happens when we start getting these random sequences is that clinicians that actually look at these images themselves, it confuses them and it thinks that we're doing something weird, and they complain. So, for instance, there was an interrography one where it's sending over the fat-only images, and then that's sent over 4 times, and then it's sent over this other, water-only, it's sent over 4 times. And the person who's seeing this, like, holy crap, they did 15 series on the same thing, I don't know what any of this means. And it just confuses them, so I really try to avoid sending the ones we don't need. Another tiny little thing that most of the RADs, I guess, prefer to have all the different phases, the actual images sent over as individual series.
You can't. That's a problem right there.
Why?
So if you have them as individual series,
But you do, though.
it
You
won't.
do a pre.
No.
Yeah.
But if you have those as individual series, the subtractions have to be individual series. We
I've
can't
seen you
make all
stack them, though. I have seen it in person
Right.
in the flesh.
when you are running them all together,
Mhm.
pre-arterial, venous, equilibrium, all in one series, that's when the subtractions are all in a single series.
I have seen it, Steve. I promise you. It came
I don't know
down.
what they're doing then.
I don't know either. Maybe it's just on the GE scanners that I'm seeing. I see,
Oh,
I realize.
that's why,
But I don't
it's
know.
together on the GE.
I don't know.
Yeah.
But if you can figure out a way to do it, maybe when next time I see it in the real world,
Yeah.
I'll call and see how did you do that. What else? And then the one thing we see all the time, I don't know what this is. It happens in North Carolina, the outpatient inpatients. It happens here. It happens in Lutheran. There's this irresistible urge to repeat in and out of phase imaging. I don't know why, but you almost never need to. And I'm just going to go over that real quick. The only exception to that is when you have really bad adrenal protocol. We're looking at these little tiny lesions, a lot of motion artifact. Feel free to repeat that. And again, when in doubt, don't hesitate to ask. So just, I figured if I explain the physics behind in and out Dixon's and in and out phase imaging, it might help everybody explain. So wherever a proton is in its environment, if it's in a bunch of fat, if it's in a bunch of water, it's going to precess, or it's going to spin just a little bit differently. And we take advantage of that. So between fat and water, there's about, I don't know, like 220 hertz difference in how fast things spin. So when you hit it with a pulse of energy, they're going to be aligned together. But as time progresses, since they're spinning at a different rate, they're going to get out of sync. Now on a 1.5 T, they're going to be completely out of sync at 2.2 milliseconds. So this means at this time, they're going to cancel each other out. And then at 4.4 seconds, they're going to be pointed right back in the same direction. At a 3T, this happens twice as fast, which is something you're going to have to see here. Actually comes into you need to consider. So the result of that is when you have a little tiny ditzel of fat and a little tiny ditzel of soft tissue or water in the same voxel, when they're out of phase, they're going to cancel each other out. And so this is a fatty liver. They're going to cancel each other out. So the whole thing looks dark. There's no signal. But on the in phase, at 4.4 milliseconds, they're back in phase. So now they're joining forces, and now you're going to have signal. And so you don't need to have a perfect image to know that that's darker than that. And that's why you almost never need to repeat it. And this is about 98% of the case we're going to see is with fatty liver. And I know you're thinking, you say, okay, if this has a longer TE, what can I use this for? Well, the echo time is longer, so you're going to get more susceptibility artifact. For whatever reason in Denver, I feel like nobody has hemosiderosis or iron deposition. I don't know if it's because people aren't getting transfusions or people aren't that sick in the outpatient setting. But what happens is on this sequence, if you have iron deposition, so if you have some weird disease where you got to get a bunch of blood transfusions, you start storing a lot of iron. Or if you have this thing called hemochromatosis, you just can't get rid of iron, you're just constantly absorbing it. And it's going to be completely flipped for the liver. So the longer echo time, the liver, the spleen, the bone marrow, the pancreas, all that's going to be dark. I don't know if this makes any sense, but what happens on a 3T machine is because it goes so much faster, people will put the out of phase second. And so what happens is when you have iron deposition, it makes it look like you don't know if it's iron deposition or a fatty liver, but I guess that's not really a problem here since we mostly have just 1.5 Ts. But that's the physics behind it. That's why you don't need a lot of resolution, just big bulk, bulk images. On the adrenal protocol, same thing. In an adenoma, you're going to have fat and water in the same little voxel, so they're going to lose signal. It's going to be dark. Here's in phase. It's back to normal signal. So this is what it should be on like normal or in a pretty big sized lesion. But when you have like a tiny little distal that's like this big, and then yeah, I'd probably repeat it. But other than that, I would almost never repeat in the non-phase imaging. Just waste time, and it just when it happens is people repeat this and then they'll send over the fat and water only. All of a sudden you've gone from 2 series to 8 series. And then it's just, I don't know, just a lot of people like this some referring physicians see that. In their mind, we scan that person 8 different times, and they don't know why, and then they call me and complain. Don't be scared of the final thought is don't be scared to increase slice thickness, especially in the vibes to the breath hold. I know a lot of people do CT and MR, and there's this notion in CT that we need thinner slices. But that makes it harder to read. But in MR, it's I'd much rather read a 6 millimeter thick slice, which has a 12-second breath hold in an 80-year-old woman, than a 4 millimeter thick slice with a 30-second breath hold, which is impossible. So especially in the vibes, feel free to increase. They're almost always at 4 millimeters, but I mean, please, for all means, increase it to 5 millimeters. And that 85-year-old lady who probably should not be in the MRI scanner, go up to 6 millimeters if you need to, just to get good images.
I would echo what I said about motion for CT with MR. It's really critical to have still images. So if we're sacrificing a little bit of spatial resolution to get a shorter breath hold to get stiller images, we'll end up with a better quality.
Yeah, absolutely. That's really all I have. If you have any more questions or anything.
So when we do our abdomens, you don't want us to stack the vibes, just stack the subs?
Well, if it can be done. So I guess,
I'll
you may be right. I may be just seeing my mind.
Well, we manually stack our vibes, so like when you get the sequence that says stacked vibes,
Yeah.
that's what we did.
Oh, subtractions?
Yeah.
So then, when you do that, then you can click a button and it auto subtracts, and then it puts it all in one series.
I
When
prefer to
it's not-
stack all done together, but there's a few radiologists that have been doing this for a long time that have to have them separate. They don't realize you can just drag the thing down and put them next to each other, but I don't know, they've been a lot longer than I have, so I complain and change their way of thinking.
Yeah.
I just don't like a lot of series, like especially so high-rise chest he's using the repeated. It's like, I gotta take it in my hand. Keep this thing going. The other issues.
So what does the Blade T2 give you versus the regular T2? You mentioned
So-
that in there.
Blade apparently some sequence, and they love these stupid names. And G, I think, is propeller. And acquired, it fills case space in a radial connection.
Well, I know what it does, but why do you want it?
Because it reduces motion artifact. So
Okay.
for whatever
So
reason,
it's just-
yeah, it lowers
You just
motion.
want one.
There's some article out there that says in the pelvis that it can lower your signal to noise ratio. So you may not see good discrimination on variances.
Yeah.
Who knows? I mean,
Part
that's
of
probably-
the problem why we don't do blades all the time is because they are a little longer, and if you have the patient's arms down,
Mhm.
which is how most people want to lag in there, you'll see that blade artifact showing up. So
Interesting.
I guess what we could do is maybe do it at the end, towards the end, and just have them put their arms up, just for that part.
Yeah.
Because it's hard for them, 45 minutes with their arms over their head. It's really hard.
Yeah, that's probably pretty claustrophobic too. What about like oversampling or doing anything like that? Is that
But then you're upping your time even more.
That's
That's
true.
our big problem is time.
Well, yeah,
Especially with
blade,
those breath holds.
if you can do blade, again, increase the slice thickness to 5 millimeters if you need to. I would actually all run them at 5 millimeters. I wouldn't do anything thinner than that. But yeah, it's shown to significantly reduce motion artifacts. So if you can do that, I would use it both in the abdomen and in the pelvis. But let me think of one other thing.
Well, the pelvis is easy because they put their arms up like this and it's not showing up. But for the abdomen, it's kind of a pain.
Along those lines, when you see when there's a new MRI tech, I've noticed that they tend to make the field of view gigantic. Like we don't need to see the arms when we look at the abdomen. And it sounds silly, but it's like trying to read a book standing 4 feet away. I realize that by making a huge field of view, your voxel size is going to be bigger, so you're going to have more SNRs that make things supposedly look better. But you have to think from our standpoint, it's much easier to actually looks like something close. So it's one little thing that it recurs all the time, but just if you see, like, there's a new MRI tech, you see they're gonna add it, it's fine.